Here we go. We've got another episode of The Standard coming to you right now. This guy we've already talked to once, but he had such good stuff that I wanted to get back to him. And he's been so active on the social media and just dropping little nuggets of information that I just wanted to bring that into one place so that we could distribute that out to as many people as we possibly can. So this guy, like I said, we've talked to him before. He's got some really, really great information to share, some evidence-based research to share, and it's in a world that's not always in the respiratory therapy like container, but I do know that there are areas of the country that do utilize vascular access. And yes, we are talking to a guy who absolutely brings it every time that he's here, and I'm excited to share this moment and this time with him again. So without further ado, let's get into it. All right, so we got the vascular guy that is back. He was with us a couple of weeks ago. We talked about vascular access. He has been just blowing up the social medias with so many amazing responses to the questions that you guys have when it comes to just procedures with not only the ultrasound, but anything that goes with needling or IVs or PICCs or central lines, things of that nature. So lots and lots of really good stuff coming out of this guy right now. So if you want to just give us a quick rundown introduction again, the vascular guy, let's hear it.
Yeah. Vascular access is my thing. So I've been doing this since I was in the ER, I think since 2015 or 16. And then switched over to PICC lines, and now we're doing CBCs and just running with it and love it. Yeah. So I found my niche, which is really nice.
Yes,
that is vascular
awesome.
access. So passionate.
Yes.
I don't even know why. Have to do some self-reflecting, but I'm really passionate about it. Like, I really enjoy it. I want to know more about it. I want to be the expert in it. There's so many smarter people out there, and I want to catch up. And I'm doing my best to increase my knowledge, my skill base, my experience, my intuition, and that all comes with practice. So yeah, I really, really enjoy it, and for whatever reason, I think I'm good at it. We'll see.
Well, I just love that. Like, there's a lot of like internal reflection and understanding of yourself to know that, you know, even though you have a certain skill level in it, you realize that there's other people out there that you want to try to catch, right? And that is really, really cool, and it shows like a maturation process in not only yourself, but also the growth from, you know, probably that ED time whenever you were just starting out as a nurse to where you are now. So kudos to you for that. So why we wanted to do another episode, why we wanted to bring you in again is again stemming from those social media, those TikToks and those Instagrams that you've been putting out. And one of the questions that I saw, and it was a couple of weeks back, is you were advocating for subclavian CVCs versus IJs. And I was lucky enough to be a part of a team that was doing CVCs, but they were adamant that we weren't going to do those subclavian lines. And there was rationale behind that, and I understood it at that time, but you brought forth some evidence that I want to bring out of you today that may enlighten even, you know, those beyond our circle. So just kind of talk to us a little bit about, you know, the subclavian versus the IJ.
I'd be happy to. So there is a huge stigma against pneumothorax. Rightfully so. It is a dangerous complication. It's not something to be like taken lightly. The data doesn't make sense for us to be more emotionally fearful of pneumos than we are of CLABSI. And the data shows, but it doesn't hit us because with CLABSIs, it's hard to pinpoint whose fault it is. Even if the insertion was done poorly, If a week later there's no infection at the site, it's not the inserter's fault. So then whose fault is it? Is it out of the 20, 30 nurses that took care of it that week? Is it the patient's immune response? Was it from the blood draw? Like, there's so many variables to contribute to CLABSIs that no one person can be blamed or scapegoated for CLABSIs. An institution will be because they're paying for it, but not one person. But a pneumo, we know exactly who did that.
Right.
And
right.
we're talking about specifically the iatrogenic pneumo. So there's traumatic pneumo, there is closed tension pneumo, spontaneous pneumo, and iatrogenic. So iatrogenic is pneumos caused by procedures. So we caused it during a procedure. Those specifically, we know exactly who did that one.
Right.
So like Dr. Liddell, I was listening to his one of his talks, and he was saying, look, CLABSI, no one gets blamed for it. There's no name attached to the CLABSI. It's not like, hey, Jenny or Steven, you caused that CLABSI. There's no finger pointing on an exact individual. But if I cause a pneumo, my cousin in California, who's interventional radiologist, he's going to hear about it, right? It's a very close circle, and it's like, oh my God, did you hear? The vascular guy, he caused the pneumo.
Right.
Everyone's going to hear about that, right? Because we know exactly who to pinpoint it to. It's a sentinel event, so we make it a bigger deal. But when looking at the data, it's not as big of a deal. It's still a big deal, but not as big of a deal, not even close to what a CLABSI is. And so I found that very interesting. And it wasn't like I discovered it. No way. Dr. Liddell was speaking on why the axillary or subclavian, some people call it, why this approach is more important than the IJ. And it's because the infection rates from IJs there's such a higher rate of infection with IJs that the subclavian is a better alternative. And it has a lot to do with the care and maintenance issue. And this is a huge disconnect between the inserters and the nurses who are taking care of these lines. Huge disconnect. Even from like the little stupid thing, like the disc rotating like 180 degrees. Like you probably saw a lot of my TikToks. Like I kind of rag on people who do that. Those are people who've never, ever changed those dressings. Or they were taught by their preceptors, this is how you're supposed to do it. And it's just been passed down that way when it's actually against IFU and not recommended. It's actually contraindicated to do it that way. But they still do it because they never needed to deal with it. They never need changes, so they don't know why. Why does this keep pulling? Why do you guys keep pulling out the lines? Why does it keep dislodging? But a lot of it's during the dressing changes, and that's because of the way we inserted it. So IJs, CDC recommends subclavian axillary approach over IJs because of the infection rates are so high. They say don't do the IJ. It's like it's so clear that the CDC is against IJs. And why? Because it's such a high risk for infection, and it's because of the way we're placing it. Our CLABSI rates will go down if we placed it correctly with the IJ. But unfortunately, it's such an antiquated technique in residency and taught the old way of IJs, right? Mid-neck, where you can feel it away from the chest cavity. So the further away you are from the chest, the less likely you're going to cause a pneumo. That's correct. But what people are not realizing is that's an old practice because they were doing that blind. Correct. They weren't using the ultrasound. They weren't visualizing and being able to see exactly where that needle point was. And because of that, they recommended avoiding the IJ, in which 100% agree. If you're going in blind, you better go mid-neck. Right? Because you need a lot of room not to tap that pleural cavity.
The apex of the lung. Yeah. Is there a way you can identify lung whenever you're scanning in that area?
100%. So there's a thing called the receiver protocol, which I'm finding out a lot of residents are not being taught this. I work with a company that consults for CLABSI reduction. One of the biggest things we're finding is that there's a big resistance against supervising residents to insert properly, to teach and pass down proper technique. Attendings are like, I don't have time for it. I'm too busy. Okay, I get it, right? But also, the legacy of these residents is going to be subpar, right?
Ultimately,
The
the
legacy that
patient
you're passing.
suffers in that
Oh
case,
my
right? Because
gosh,
the
yeah.
resident's not getting the best technique or the best practice for that procedure. 100%.
They're
I mean,
they're
I've
winging it.
seen it as well.
They're winging it. Like they're like, this is what was said in the book or what was said in YouTube, and that's
Yeah.
all they're going off of. Or we're finding out there's subpar training, and it's old, antiquated techniques that's not even being supervised most of it.
So what's the updated technique? Where are we trying to get?
So biggest thing is the use of the ultrasound. Okay, point of care ultrasound during insertion is the biggest game changer that's not being utilized. There's more adoption in the nursing world, almost 100% in the RT world. Like you guys, I think you guys are like really updated with the technology here. I'm finding that a lot of doctors are still not being taught ultrasound for insertions, and it's blowing my mind. Like, guys, we have this awesome technique. You know what you're looking at. Why aren't you using it? It's because I wasn't taught this way. That's all it is. Let's say pre-ultrasound. Yes, IJ is the best. Avoid the axillary subclavian. Lower IJ is probably dangerous as well. But with the ultrasound, game changer. You can see where it is. You don't have to keep going. When you see that needle tapping that vein, you don't have to keep poking it through to the lung. You can avoid that, right? And so that's what changed the game. The problem with the mid IJ is that a lot of it just sticks out like this. And the problem with this is that gravity's constantly pulling on that line. And I have a bunch of pictures out there to show. If you're a nurse, you know, or an RT, you know that these are problematic and you hate these. And actually, you do everything you can, getting a PICC line placed, getting a midline placed. You do whatever you can to get rid of this, right? It's like they really hate working with these, and that's because they can't keep that dressing on there. They're having a hard time preventing that infection. So let's put it here, or at least when you put it in the lower neck, at least turn it down to the chest so that the dressing can stay on the patient and not get disrupted from range of motion.
The infection rate is decreased significantly by going axillary or subclavian versus the IJ. Is that
correct?
Is that what I was picking up? So if we're able to reduce that infection rate, because you were saying it's a big deal, right? Right? It's a big deal to go subclavian versus IJ. And I just want to make sure that I'm getting this right so that everybody else is getting it right too. Is the big deal part of it is the reduction of the infection, right? The reduction of the possibility of the infection from IJ to subclavian or axillary. So do you have anything on like mortality rates from IJ versus subclavian?
Yes. So a pneumothorax, the mortality rate of a pneumothorax is less than 1%. And this is straight from Dr. Ledun's talk that I was listening to, and also from his research and his studies. CLABSI, which there's more incidences of CLABSI, first of all, right? So more volume, not including that, 12 to 25% mortality rate. Not only is there more CLABSI than there are pneumos, there's more people dying from CLABSI. We're talking about thousands, possibly tens of thousands more people dying from a CLABSI than from a pneumo. We're worried about the wrong thing. We should be worried about this massive, deadly force called the CLABSI rather than the pneumo. So that's why the emphasis of trying to avoid the CLABSI is there. Doing whatever we can to avoid the infection by even just changing our insertion site, the risk of a pneumo is worth reducing the CLABSI. Why? Because if you know you tapped it and you caused that pneumo, that you don't see sliding lung, which you should check after every CVC attempt, you're like, what do we do? Chest tube or decompression needle, right?
Right.
It's an easy fix. We know how to fix it. Yes, it's going to be costly, but the cost of a CLABSI, now let's go into money. It was about $14,000 to $20,000 is what it costs for a pneumo. That's a chest tube, the procedure, or decompression, whatever it is to treat that pneumo is about $20,000. A CLABSI that infection is 45,000 and up. Okay, so it's significantly more expensive, not even including the mortality rate, not including the cost of life.
So I'm going to throw a little curveball at you here. This is the rationale, one of the rationales they didn't want us to do the axillary or the subclavian is, one, the pneumo risk, but two, compression of the artery if you happen to hit or nick that. You're not able to compress as a result of the clavicle being there. But it's mitigated because we are using ultrasound, right? You're using ultrasound with your subclavians?
Oh, of course, yeah.
So
I don't insert anything without the ultrasound.
So you're able to differentiate your artery versus your vein. So as like a program progresses, do you think moving to the axillary to the subclavian is something that can be progressed to once that ultrasound guided needling is proficient?
That's a good question. Yes, I think, which is not going to happen because the need for these central lines are so great. People are going to be rushed through it. They're no good under the ultrasound because they don't have enough supervision, especially with complicated cases. Like, have you ever seen those IJs where they like go like this, like completely collapse and open up? It's like, oh, it's big, and then you're like, uh-oh,
and then it's gone.
Like
100%.
it's basic. It's a moving target. How do you tap that? If you're not familiar with visualizing your needle and understanding that you just wait for that inflation to hit and then you pop through and then if you don't even know how to thread the needle, all those little techniques, you can't be taught in like 2 or 3 attempts. That's like after 50. I mean, of course they can progress, but are they willing to let them progress from PICC line? Because I think they all should start at PICC lines, midlines, PICC lines, then progress to IJs, and then possibly the axillary, or even the axillary first, depends on what they're familiar with. I think a lot of people will tap the artery because they're bullshitting themselves. They're saying, I think it is.
Yeah.
Right. And then even after they poke, they don't even know that they hit an artery. They don't even know from seeing the blood, the pulsation of the blood, they don't even know how to assess, even if they're in there, to assess whether it's an artery or not. And a lot of times I think also they kind of have an idea it's not in the right spot, but they don't want to admit it. So they're like, okay, I think we're good. Send it to X-ray, and then they'll confirm it or not, and then someone else can deal with it.
So do you have a number of successful lines that you've placed with ultrasound?
Over 1,000 successful sticks a year. Oh my gosh.
My follow-up question to that is, how many did you have to attempt with the ultrasound and the coordination to feel confident and get to that proficient or expert level?
I would say now feeling and actual are two different things. So I felt proficient probably after my 3rd year of ultrasound insertion. I became proficient probably my 4th or 5th year. And I was being more careful about which ones I attempt and which ones I don't. I wasn't attempting every single line.
So the whole reason behind those questions is that they understand that it takes time. You can't do this 2 or 3, 4, 5 times and feel like you are the person in this, right? So to encourage somebody to take the time and to get the reps and to, like you said, you were doing multiple, like 1,000 a year now, and you thought you were proficient at probably around 3,000, but now you've gotten to the point to where you understand the difference between thinking you are and actually being, and it takes multiple years of perfecting that technique, right, and growing in that. So those that pick up an ultrasound for the first time and it's a tough motion. It's a tough motion to master. And I can tell you from my experiences, we spent a week in a simulation lab doing mannequin, right? In a controlled environment with a mannequin. and just grew from there, right? But not everybody gets that training. So understanding that when you put that probe on the patient and identifying your structures and your vessels and your nerves and everything else, right? It takes time to build that skill. Just to emphasize that it takes time and thousands of reps to become proficient.
So then let's go take it a step further. So for those of you who are just starting out inserting, I got my first stick. Everything I do, first time I do it, I get it right. But the next 10 attempts, I bomb. Ultrasound IV, got it. We were practicing on each other, got it in, first stick, felt great, right? And then the next 10 sticks, I was like, man, I cannot get these in. Right. So you have to push through that hump of your failures and give yourself some forgiveness. Say, okay, I'm just learning. What did I do wrong this time? Think through it and then reattempt with adjustments to what you did last time.
One of my favorite, leadership presenters, Dr. John Maxwell, he says the best teacher is evaluated experience. And that's exactly what you just offered, is go through that experience, reflect on it, and grow.
So I sucked at the beginning, but I kept trying because I knew I wanted to be really good at this one day. Made it a goal, like, look, I suck now, but someone's really going to need this. I need to get to that point. So let me get my practice in.
There's another saying, it's you learn, apply, unlearn, relearn, apply.
Ooh. That unlearning is, I think, one of the harder things to do. Yeah.
100%, because we that unlearning process is something that is part of that growth process. And I can speak to that. And I could go down a whole rabbit hole on that unlearning process, but evaluated experience is the best teacher. So I would encourage you guys, just as he did, to go experience and evaluate your process through that experience and then grow from there. So, brother, this was really good. I'm glad you brought this information to us. If anybody has any questions for you, where can they reach you?
The Vascular Guy everywhere. YouTube, Instagram, TikTok, those main things. If you Google it, you'll find it. So DM me, direct message me, feel free to reach out. And I want to help you guys. I even do like one-on-one. So I actually get paid to train people on this outside of the social media. So take advantage of my extra time that I have. Free lesson. I want you guys to get really good because I really want to push this ultrasound insertion technique because it's really a game changer. We don't have to stick 15 times. Stick yourself with the needle 16, 20 times. You're putting your patients through that. You don't have to anymore. We have the ultrasound machine. We have these techniques that we developed. Let's go. Let's stop dragging our feet. We're here. We're in the future.
And I can 100% attest to him answering his DMs. That's exactly how we got connected. He had a video. We friended each other, and I sent him a question like, hey, what's up with this? And then we just started the dialogue, and that's how this whole thing transpired. So he's 100% reachable. He's a nice guy, just because we want to spread the best practice, right? The better practice, because if you think you're the best, you never want to get better. But anyways, that's a whole different thing. But that's the whole idea behind this little channel right here, this playlist, is to identify better practices and then share the wealth with everybody. So if you have anything else you want to drop in here, this is your time to do it and close us out here, man.
No, hey, I love this. I love that people are actually interested. Please go pursue it. Be better. So yeah, man, that's it.
Awesome. Thank you so much. We'll see you guys next time.
Wow. What can I say? This guy brings it every time. I mean, the information about CLABSI rates and the mortality, the cost associated with them in comparison to pneumothorax. And what we focus on is the concern with pneumothorax. But why? Right? Why? And that is what I really, really appreciate about the Vascular Guy is he helps us understand that why. So if you haven't seen the first episode, go check that out right now. If you have seen it, go back and watch it again. You can always get new information from these videos. If you haven't done it already, subscribe, like, share this with your friends. If you want to get a hold of the Vascular Guy, I've got his links down in the description below. Or you can find him on social media, The Vascular Guy, on TikTok, Instagram. He's got a YouTube channel as well, so go give him a follow. Looking forward to doing this again with you guys very soon. Until then, go get those reps in and get better at something. There is a patient, there's a person, another human who can benefit from what you are benefiting from. So go get those reps. We'll see you guys soon.